The following podcast is part of a certified educational activity titled A Visual Exploration of Antisense Oligonucleotide Therapies in Amyotrophic Lateral Sclerosis. Access the entire activity and complete the post-test at peerview.com/DYM860. Downloadable additional resources are also available.
In the United States, the prevalence of ALS is about 5 per 100,000 people. The annual incidence is about 2 per 100,000. In systematic reviews, the peak incidence of ALS is about 60 to 75 years in the majority of the studies. Now, ALS is a progressive and fatal neuromuscular disease, and typically it affects the upper and lower motor neurons in the brain, brainstem, and spinal cord. Motor neuron cell death eventually leads to muscle weakness, and that loss of motor function is the main burden of clinical disease. It causes paralysis, it causes breathing problems, and eventually death from respiratory failure, typically within 3 to 5 years of disease onset. ALS can present in a variety of ways. Early signs and symptoms that should elevate the suspicion for ALS include muscle weakness and stiffness, muscle atrophy, muscle twitches, often called muscle fasciculations, slurred speech, difficulty chewing and swallowing. Now, it's really important to diagnose ALS as early as possible. Early and accurate diagnosis is essential for ALS patients to receive specific clinical management that can be more effective earlier in the disease course. It's also important for the correct inclusion of patients in clinical trials for targeted therapies. As I mentioned before, ALS can be different from person to person and be variable in the way it presents itself. ALS is clinically and pathophysiologically diverse, with potentially different etiologies that share a final common pathway leading to upper and lower motor neuron degeneration. There are variants of ALS, such as a pure upper motor neuron presentation. So that means patients with pure upper motor neuron presentation present with stiffness and spasticity without muscle atrophy or fasciculations, and we often refer to those patients as primary lateral sclerosis or PLS. Lower motor neuron presentations include muscle atrophy and muscle loss and weakness without hyperreflexia and spasticity. This variant is called progressive muscular atrophy. Approximately 70% of patients present with spinal onset. This means that they often have an arm or a leg that's weak at the onset of their disease. About 25% of patients have bulbar onset disease, and about 5% present with initial trunk weakness or breathing difficulties as their first onset of symptoms. Now, sporadic ALS occurs in individuals with no family history of the disease. That's approximately 90 to 95% of ALS cases. 5 to 10% of cases are familial. More than 50 potentially causative or disease-modifying genes have been identified, and many of these gene mutations are found in subsets of patients with familial and sporadic ALS. The most common genetic mutations include the Sod1, which accounts for about 15% of familial cases and approximately 2% of sporadic ALS cases. Other common genetic mutations include C9orf72, TAR-DBP, and FUS. There are many disease processes involved in ALS pathogenesis. Some of those disease processes include nucleocytoplasmic transport defects, altered RNA metabolism, impaired proteostasis, impaired DNA repair, mitochondrial dysfunction, axonal transport defects, vesicular transport defects, neuroinflammation, excitotoxicity, and oligodendrocyte dysfunction. Now I'll talk about current treatment approaches that are approved for the treatment of ALS. The first is Wrillizol. This was the first disease-modifying therapy approved for ALS. It's orally administered and works by blocking the release of glutamate and by modulating sodium channels. In a clinical trial evaluating the efficacy of Wrillizol, it extended survival by an average of 2 to 3 months. It's easy to use and well tolerated, and serious side effects included transaminitis, which is defined by a threefold increase in AST or ALT, occurring in about 2% of patients. A liquid form of Wrillizol is now available, which is helpful for patients who have difficulty swallowing pills. More recently, edaravone was approved for the treatment of ALS in the United States. It's administered intravenously. In the first month, it's given 14 days in a row, and then 10 days out of every 30 every month after that for the rest of the patient's life. In the clinical trial, there was benefit seen in a group of very early, rapidly progressive patients with well-preserved function as measured by the ALS Functional Rating Scale, also referred to as the ALS-FRSR. There were only minor side effects, and most commonly, patients experienced bruising, gait disturbance, and headaches. The mainstay of care for people living with ALS include interventions to improve quality of life. Much of that revolves around symptomatic treatments for ALS. Those include things like sialorrhea or excessive saliva, emotional lability and sleep issues, as well as spasticity and cramps, and cognitive impairment and mood disorders. Many of these symptoms are treated with pharmacological therapy indicated for that particular symptom. Supportive care approaches are also implemented in the care of people living with ALS. Much of it includes adaptation techniques or functional or rehabilitative care, things like providing durable medical equipment such as canes and walkers to help with mobility or splints to help joints that are very weak. Other supportive care approaches include providing non-invasive ventilation or cough assist devices to help with respiratory care, and providing nutritional support and care either by supplementing oral intake or diet, or providing supportive nutrition through a feeding tube. Lastly, palliative care is an important and critical part of taking care of people living with ALS, ideally since the onset of disease and diagnosis all the way through the end of their journey. The interventions I just summarized highlight the unmet need for disease-modifying therapies. Despite the approvals of Wrillizol and edaravone for the treatment of ALS, neither can halt the disease progression or cure the disease. Patients are variable and heterogeneous, and not all have a significant benefit from those already approved therapies. This means that there's a robust clinical development for newer therapies that are specifically targeting mechanisms that are occurring in the motor neuron in hopes of having a more meaningful impact on the disease and clinical burden of ALS. Now, in ALS, there's several downstream signaling pathways and mechanism of action of investigational therapies. Potential molecular pathways of the pathogenesis of ALS include abnormal RNA or nuclear processing, impaired protein clearance and abnormal protein aggregation, axonal transport dysfunction, cell autonomy and non-cell autonomy, excitotoxicity, oxidative stress, endoplasmic reticulum stress, energy pathways, and mitochondrial dysfunction, as well as neuroinflammation. There are several investigational drugs that are targeting several of these pathways. One of the investigational therapies that have demonstrated promising results in a completed clinical trial is AMX0035. The clinical trial was conducted and completed in 2020, and the results of this clinical trial was published in the New England Journal of Medicine. This drug, AMX0035, is a combination of two compounds, sodium phenylbutyrate and tauroursodeoxycholic acid. In the clinical trial, AMX0035 was able to slow the progression of disease as measured by the ALS Functional Rating Scale compared to those taking placebo. The drug itself is designed to reduce nerve cell death and inflammation by blocking key cellular pathways. Now you'll see a brief animated video that demonstrates the mechanism of action of antisense oligonucleotides in ALS.
Many genetic neurological diseases are caused by the dysfunction of single proteins. While treatments of such monogenic conditions have traditionally targeted downstream pathways, The expansion of drug discovery platforms has led to the development of antisense oligonucleotides, or ASOs, to directly target the expression of the genes that cause neurological diseases. ASOs are short, synthetic, single-stranded nucleic acid fragments that are designed to bind to complementary target messenger RNA molecules that encode a disease-related protein in order to alter RNA and downregulate, restore, or modify protein expression, depending on whether the disease is associated with a toxic gain-of-function or loss-of-function mechanism, among other factors. Mutations in the gene encoding superoxide dismutase 1, or SOD1, account for approximately 20% of familial ALS cases. Disease expression resulting from these mutations is mainly mediated by a toxic gain-of-function mechanism associated with the aggregation of the misfolded SOD1 protein. Therefore, ASO-mediated degradation of SOD1 transcript holds great potential for therapy development. The ASOs that target gain-of-function mutations in ALS are RNase H1-dependent ASOs, also known as gapmers. In order to bypass the blood-brain barrier, these gapmer ASOs are delivered to ALS patients via intrathecal injection, where they are rapidly distributed throughout the central nervous system. From there, they are taken up by neurons and glial cells in the brain and spinal cord. Once in the cells, the gapmer ASOs hybridize to the complementary targeted mRNA through Watson-Crick base pairing, creating an ASO-RNA heteroduplex. Upon creation of the heteroduplex, ASOs utilize endogenous RNase H1 enzymes to selectively cleave and hydrolyze the targeted mRNA strand, thereby preventing the translation of the degraded mRNA, which results in the downregulation of the targeted protein.
Antisense oligonucleotides target specific RNA sequences by constructing complementary oligonucleotides that bind to the native mRNA sequences and reduce their translation and subsequent protein expression, effectively downregulating or silencing mutant genes. An example of a disease where an antisense oligonucleotide is already approved and in use is spinal muscular atrophy. A clinical trial demonstrated effectiveness in slowing the onset of disease burden physically in patients with spinal muscular atrophy. In addition, the clinical trial was able to demonstrate good safety and tolerability, leading to its approval and use in patients with spinal muscular atrophy. Sod1 Als is a subset of amyotrophic lateral sclerosis categorized in the familial ALS disorders. Sod1 Als is thought to be a gain-of-function mechanism. In this version of Sod1 Als, mutant SOD1 and modified wild-type SOD1 misfold and adopt a similar conformation. These misfolded proteins form oligomers, pre-aggregates, and then aggregates. And these aggregates lead to a cascade of events that eventually lead to motor neuron degeneration. The rationale for use of antisense oligonucleotides in the treatment of Sod1 Als is that although Sod1 Als disease progression is heterogeneous, the underlying pathophysiology is attributable to mutant SOD1 toxicity. Therefore, Sod1 Als is thought to be a toxic gain-of-function mutation. As such, effective reduction of Sod1 protein, irrespective of mutation, has the potential to alter the disease course of people with Sod1 Als. Tofersen is an antisense oligonucleotide RNase H1-mediated inhibitor of Sod1 messenger RNA, which is under investigation for the potential treatment of ALS in patients carrying the Sod1 mutation. In the early phase study, phase 1-2 of tofersen, 50 patients carrying the Sod1 mutation were evaluated. Patients were randomly assigned to one of the 5 arms, placebo or one of 4 doses, which were intrathecally given over a 3-month period. The doses of tofersen included 20 milligrams, 40 milligrams, 60 milligrams, or 100 milligrams. The primary endpoint of that study was safety and tolerability, as well as pharmacokinetic measures of tofersen in the plasma and the spinal fluid. Secondary endpoint included the change from baseline in the cerebrospinal fluids level of Sod1 protein. Exploratory endpoints included clinical measures like the ALS Functional Rating Scale, vital capacity to measure breathing, and muscle testing, as well as cerebrospinal fluid phosphorylated neurofilament heavy chain. In the early phase clinical trial of tofersen, the highest dose, which was 100 milligrams, was associated with a 37% reduction in cerebrospinal fluid levels of SOD1 compared to placebo. The exploratory analyses also found that tofersen was associated with decreased plasma and CSF concentrations of phosphorylated neurofilament heavy chain and neurofilament light chain. Tofersen was safe and well tolerated in this early phase clinical trial at doses up to and including 100 milligrams in the participants with SOD1 ALS. And the pharmacokinetic data showed that tofersen concentrations were dose proportional in the plasma. At the highest doses, tofersen, which was 100 milligrams, there was a trend towards slower clinical decline of function, respiration, and strength, with greater differences in patients with rapidly progressing disease. So these measures included ALS Functional Rating Scale, the slow vital capacity, and the handheld dynamometry measures for muscle strength, also referred to as the megascore. Based on the early phase clinical trial results of tofersen, phase 3 was initiated. The phase 3 clinical trial is called VALOR, and it involves a number of patients with SOD1 ALS. In this study, the primary outcome measure included rates of adverse events and abnormal clinical signs, pharmacokinetic parameters, and the change in the ALS Functional Rating Scale over the course of 28 weeks. Secondary outcomes include the change in the cerebrospinal SOD1 levels, ventilation-free survival, and overall survival. Long-term safety extension study is also ongoing and will be including patients that completed the main placebo-controlled study. Additionally, tofersen gives us an opportunity to evaluate whether there is an effect on pre-symptomatic individuals that carry the SOD1 mutation. There is currently a pre-symptomatic study that's being designed to evaluate whether tofersen can delay clinical onset or slow disease progression of ALS in SOD1 carriers. This study is anticipated to initiate in 2021. Antisense oligonucleotide technology can be applied to the C9orf72 version of ALS. The C9orf72 hexanucleotide repeat expansion is the most common genetic mutation identified in patients with amyotrophic lateral sclerosis. It accounts for about 30 to 40% of familial cases and up to 12% of total ALS cases. BIIB078 is an antisense oligonucleotide designed to decrease mutant C9orf72 while maintaining expression of the normal allele. Currently, it's being investigated in a phase 1 clinical trial evaluating ALS patients that carry the pathogenic mutation in C9orf72. This study is planned to complete in 2021. Another potential target using antisense oligonucleotide technology is Ataxin 2. Aggregates of TDP-43 protein in motor neurons is a pathology common to over 90% of ALS population and induces toxicity in the motor neurons. Ataxin 2 has been shown to modulate TDP-43 toxicity. Human genetic data have also identified a link between Ataxin 2 and ALS. So the hypothesis is that the reduction of Ataxin 2 will ameliorate underlying TDP-43 pathology and reverse or prevent disease progression, therefore providing therapeutic benefit to most patients with ALS. BIIB105 is an investigational therapy that's an antisense oligonucleotide targeting Ataxin 2 RNA. It's designed to reduce production of Ataxin 2 protein. It's currently in development as a potential therapy for patients with most forms of ALS. Now we'll move on to discuss the precision medicine in ALS and how we get there. ALS is a clinically and pathophysiologically diverse disease, and it's associated with many genes and disease mechanisms. Therefore, many different targeted treatment strategies will be required to effectively manage the disease across all patients. We also need to increase clinical trial participation so that targeted therapies can be developed and tested. We need to improve strategies for providing effective education to patients about clinical trial participation. Strategies that include providing information to all centers that may or may not be participating in clinical trials, providing educational webinars, or even providing searchable clinical trial databases so that patients can identify which trials they may be eligible for. We also need ways to improve access to clinical trials and make them more patient-friendly. Some of the ways that the field has tried to improve clinical trial access is involving patients and their caregivers in the clinical trial design process before it launches. We also try to collect the most important clinical safety and efficacy data so that the trial visits are not burdensome for patients and their caregivers when they come. We try to expand the eligibility criteria if possible and based on the mechanism of action of a particular investigational therapy. This will allow more patients to gain access to clinical trials. Additionally, if we are able to enable access to open label extension, especially for investigational therapies in late phase clinical development, this may also increase access for investigational therapies among ALS patients. Genetic testing is a requirement for gene-specific therapies such as tofersen, which is targeting Sod1 Als, and BIIB078, which targets C9orf72. So it needs to be incorporated into routine management of ALS after targeted therapies become available. It's recommended that all patients diagnosed with ALS be tested to determine whether or not they have a targetable mutation. Typically in practice, because of the lack of therapies, this wasn't a priority, but the landscape of clinical practice globally has been changing given that there is availability and development of investigational therapies targeting specific genetic mutations. Currently, U.S. management guidelines for ALS does not address the issue of genetic testing, and the European Federation of Neurological Societies recommend genetic testing only in symptomatic patients with a family history of ALS and not in patients with sporadic ALS. The community has to discuss the ethics regarding genetic testing of family members of patients who test positive for a familiar form of ALS. This area is constantly shifting, and as therapies mature and develop in the clinical development pipeline for targeted gene mutations in ALS, this becomes an important priority. Additionally, biomarkers will gain importance once a targeted disease-modifying therapy is approved. Biomarkers are really important for several scenarios in ALS, including diagnostic use, predictive use, and prognostic use. Biomarkers will be used to identify potential clinical trial participants for pre-symptomatic trials that are more sensitive and specific markers for ALS. Biomarkers will help with measurements of disease activity and progression, and biomarkers can potentially help us judge whether an investigational product has a treatment benefit. Some of those biomarkers may be blood or CSF neurofilament. Particularly, the most advanced biomarker is CSF neurofilament, both light chain and phosphorylated neurofilament heavy chain. Other cerebrospinal fluid markers that are under development include TDP43, chitotriosidase, IL-6, MCP1, VEGF, poly-GP, especially for C9orf72, and then, of course, SOD1 protein in the spinal fluid for SOD1 patients. In blood, serum neurofilament is the most advanced, but other things that target neuroinflammation can evaluate things like T cells in the blood, cytokines, and other proteomic and metabolomic and oxidative stress markers that are still research-based markers for ALS. Another novel marker that's being evaluated in the urine is urine P75 extracellular domain. It's the extracellular domain of neurotrophin receptor, and it's been shown in several studies to show elevation in ALS patients compared to controls. This also requires future work for validation. All of these markers can help, if they're validated, to determine whether an investigational product is affecting the targeted pathways, and hopefully in the future, they'll help to make an early determination of whether patients are benefiting from that particular treatment targeting that pathway. Thank you for joining us for the discussion of Antisense Oligonucleotides for the treatment of ALS. We hope you enjoyed the program.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DYM860. This activity is supported by an educational grant from Biogen. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.